several things that have to do with mental health. And then at the very end, we'll do a little bit about sort of what the mood state profile looks like in athletes, and as kind of a way to talk about, is that just what makes a person an athlete, or is this kind of the consequence of in some ways being very, very active. Okay, so I'm gonna go ahead and do the share screen. So we're going to talk about a couple of things, and then we'll bring up how you guys did on your questionnaires, and I'll share some information about my things there as well. Okay. All right. So what I think is the best place to begin when we're going to talk about psychological states, which is in many ways kind of what mental health is going to be about. Okay, we have to understand how we measure these things, how we assess these things, so that we can understand the limitations and how they're different than measuring more physiological kind of related variables. Okay. So when we're going to ask you about a mood state, we have to rely on you to self-report those things for us. Okay. Unlike measuring, say, heart rate, or measuring the levels of a hormone in the blood, or having you do a VO2 max test, or having you lift a certain amount of weight, the tests that we do when we assess psychological states are what we call subjective. Okay, they are self-report and they are subjective, and so we have to rely on you to tell us and describe for us what you are thinking, what you are feeling, what you are experiencing. Okay, and we also have to acknowledge that the way that I feel when I am anxious may be qualitatively, okay, it may feel and look a little bit different than how Kiana might feel when she is anxious, or how Rachel might feel if she is anxious, or Madison or Lindsay. All of us may, because it is subjective, all of us may experience each of these things in a somewhat different manner. And so that to me is really interesting and fascinating from a scientific standpoint, but it does create some difficulties for us at times in how we assess things. Okay, that's part of why there were 20 questions on each side of the anxiety questionnaire, asking you different things. It's asking the same questions, right? It's basically asking you, how much are you worrying? But it's asking about it in slightly different ways, because that's helping us to try to capture how different people may experience their anxiety. Okay, so we'll talk about kind of how those instruments came about, and how they are kind of sometimes fraught with peril. The other issue with things being subjective, okay, is that people can and will lie to us. Okay, so I could pick one of you and ask you how you're doing, and you may be having the worst day you've ever had in your entire life. And you might tell me, oh, no, I'm fine. No big deal, Dr. Black. I got this. I'm fine, right? Or you may be doing great, but you may think, oh, well, he's really interested in studying how anxious we are, so I'm going to tell him that I'm very, very anxious. So that's the other side of things being subjective, is that we're relying on the people that we're assessing to be honest with us about all of this, much like we're relying on them to be honest about their cardiovascular risk factors and things so we can keep them safe. We also have to rely on them to be honest. Okay, so that's some things about the nature of using questionnaires and using the assessments. The other thing that we've got to be really careful about when we're asking you about, are you anxious? Are you sad? Right? Do you feel depressed? How are you feeling about yourself from a self-worth standpoint? Are you experiencing mental clarity or mental confusion? How energetic do you feel today? We have to try to make some distinctions between Are those feelings that you're having, are they transitory or are they more permanent, right? Which is part of what the instructions in our questionnaires are going to try to get at. So we may ask you, are you feeling a certain way right now? And then how long have you felt that way? Or tell us about how you're feeling in a more general kind of global manner, because you may experience the same psychological state, but we may call it different things. Like we all have instances where we feel anxious acutely, right? You're going to have to take a test for me this afternoon, and then it's going to be due tomorrow. So that may make you anxious, right? You are going to, maybe going to go home or go see some people for the 4th of July, right? That may make you feel very energetic and happy. But then as soon as if you leave and you come back for classes again next Monday, then that may all go away. So we need to ask some questions about all of that. We have to be careful about how we frame, how we're assessing our particular mood. And then we also have to realize that there are many different psychological states. Okay, we'll talk about how they exist on kind of a continuum in the next slide. But the other thing that we need to know that can be helpful for us is not just, are you experiencing something, but we also need to try to quantify, okay, the intensity of that particular feeling, right? How intense is it? And so for a lot of different moods, people will people will ask you things like, sort of, what are you feeling? Which may be, think of it, if you're a music person, kind of what you're feeling is, are you listening to jazz, or are you listening to classical music, or are you listening to hip hop? Like, what is it that you're hearing? Okay. And then intensity may be more described as, what is the volume at which you're hearing that particular music. Okay. And so you may be experiencing anxiety, or you may be experiencing anger or something, but it may not be very, very intense. It may be this kind of low level of intensity, and that may be very different than if it was at this very high intensity. So we need to quantify not only the presence of something, but also in some ways its intensity. Okay. Everybody with me so far? Like, blink your things at me if you're with me. If you're with me so far. Yeah, there I'm seeing some people. Okay. Excellent. Okay. So the next piece of all of this, all right, is very often we will describe psychological states as being a mood or being an emotion. Okay. And so generally, moods are going to be things that last longer than emotions. Okay. Now, it's really difficult for us to put some very, very specific amounts of time onto these things. Okay. It's not like I can tell you, okay, you've been experiencing this particular emotion for 20 minutes, now it's become a mood, or it's been 2 days, and so now for sure it's a mood. It's just going to vary a little bit. But in general, when we talk about moods versus talking about emotions, moods are things that are much more sustained. Emotions tend to be short term, right? I am mad at this person because they ran their car into mine. Okay. That would be an emotion in some ways, right? I am upset because I don't know, I got stung by a bee or something, whatever, I don't know, whatever it is that would upset you. That could be an emotion, short term, and then we kind of do something else and we move on. Okay. So most of the stuff that we look at from a kind of how physical activity is going to have some impacts on things are going to be on moods much more so than emotions. So there is some evidence that, if you're angry right now and you're experiencing that emotion, go do CrossFit and you may be less angry. But what we are really concerned about are what we call mood disorders. And mood disorders are these kind of prolonged, intense, negative feelings that may be sustained, okay, weeks or months, right? You have an anxiety disorder, as we'll talk about. Depression is a mood disorder, okay? Somebody may have issues with sort of anger and those things, that would be a mood disorder, right? And so we're going to focus much more so on these much longer, much more sustained kinds of questions. And we will highlight that when we get into anxiety, talking about that. We will highlight how the questionnaire that I gave you is asking about sort of your anxiety as an emotion on one side, and then your anxiety as much more of a mood on the other side. Okay. So when we are assessing moods or emotions or psychological states, the best way for me to try to have you guys conceptualize this is that these things exist on a continuum. Okay. And so think of that continuum as a line. And on one side of the line, we have one particular kind of the negative side of the mood. And then on the other side of it, we have the very positive side of that mood. Okay. And so I can ask you very general things. Okay. I can generally ask you about your psychological state or your mood. And I can say something like, generally, over the past 6 months, have you been in a pleasant mood or an unpleasant mood? And I would ask you to say, okay, put a mark on this line. Tell me where you fall between these two particular things. Okay. Are you way over here, very, very near to sort of pleasant all the time? Are you way over here, very near to unpleasant all the time? So they exist on a continuum. Okay. But what I also want you to look at with this is that sometimes what we think of as two ends of the continuum are in fact very different moods. Okay. So we can ask specific things like, are you feeling depressed or are you feeling happy? Okay. Those are different ends of the same continuum as we're really looking at depression. We can look from, say, anxious to calm. That would be two ends of the same continuum. But one of the things that you guys filled out on the profile of mood states that we're going to get at with our scoring is the idea of fatigue and the idea of something that we call vigor, which is basically energy. Okay. And so you might think, I am very fatigued on one end, I have lots of energy on the other end. Okay. But those are actually considered to be two separate psychological states or two separate moods. So I could be very fatigued, but also feel like I have lots of energy. Okay, because they're assessing different things or vice versa. So we'll get into that a little bit more so as we move along. Okay. So once we've done some of this, all right, we need to kind of get at how are we going to ask the questions? What sorts of questions are we gonna get at? So one of the questionnaires that I gave you is called the Profile of Mood States. It was 30 questions, and it's going to assess 6 different dimensions. Okay, 6 dimensions of sort of 6 different moods: anxiety, depression, anger, fatigue, confusion, and vigor. Okay. And so what it does then is we can alter by how we tell you things to do that assessment over, say, the past week, or just for how you're feeling today, or over the past month. Okay. And so I'm going to ask 5 questions that are going to each ask about one of these 6 dimensions. All right. And you provide a rating of, are you experiencing that particular part of that mood or that word that describes that mood, from, you're going to get a 0 if it's not at all, up to a 4 that if you are, extremely, you're experiencing that, in a very, very extreme way. Okay. So what I want you guys to do right now, okay, is I want you all to pull up your why can I not think right now? Pull up the Excel spreadsheet that had the POMS scoring in it. Okay. And what I want you guys to look at on your own version of that is there are going to be the categories for the moods across the very top of it. Okay. And there's going to be a score that you can get. Okay. And the highest score that you can get on each of those dimensions is going to be a 20. Okay, your possible score could range from 0 to a 20 in each one of those dimensions. And I believe that it may just be scored where you're going to have like the A category and the C category. So like A is for anger, T is for tension, which is really anxiety, C is for confusion, F is for fatigue, V is for vigor, D is for depression. Okay, so if you have that up and you can see your scores, then flash your camera at me so that I can know that we're in a place that we can continue, because it will be helpful as we talk about things for you guys to do that. Okay. All right. Well, there are a few of you that either don't have it up, don't have the ability to have it up, or are just here in spirit but not in actual person to be able to do that. So look at those scores. Okay. Now we consider five of those moods to be what we would call negative. It would be negative mood states. Okay, all of them but vigor are considered to be negative mood states. So fatigue, anger, depression, tension or anxiety, and confusion are going to be negative mood states. And then vigor or energy is going to be our one positive mood state. So we can interpret the palms in a couple of different manners. The first thing that we can do is we can look at your score in any one particular dimension. Okay. And so the higher you are scoring, the closer to 20 you are on any of those dimensions, then the more intense you are experiencing that particular mood state or have been experiencing that particular mood state over kind of the recent past. Okay. So that's going to be, and you guys are probably going to want to ask me, and we'll look at it a little bit later on. And I don't have the normative values in front of me for whatever this is, but typically if 20 is going to be the max, then kind of normative values across the population are, for each of those dimensions, are probably going to be somewhere between maybe 7 and 10 on any of those particular dimensions. If you're in sort of the mid-teens to the high teens on some of these things, this is not one of the questionnaires that we would use to clinically diagnose you with some type of mood disorder, but it does give us some kind of ideas. Okay. The other way that we can do things with the palms is we can calculate by adding all of these scores together. Excuse me. We can calculate something called a total mood disturbance, or TMD, as it may be abbreviated in the Excel sheet. And so if you look over, I believe the Excel sheet will calculate that. It's just adding together all of the negative mood states and then subtracting your vigor score from that. Okay. And so the highest possible score that you could get on there would be 100. That would be the most negative. You would be at 20 on all of your negative mood states and 0 on vigor. So the higher that is, then the more your total mood disturbance is. And so this can also give us some level of idea on, in a very general sense, are people, are you feeling pretty good? Are you feeling pretty crappy or not? Okay. Okay. So for those of you that did fill this out, what were your impressions? Did you think, with your scores and things, do you think that accurately describes you? I guess that would be my question. And I'm not going to ask anybody to share your scores if you don't want to, but just kind of look at that and think, yeah, I have been feeling pretty fatigued, or yeah, I have been feeling, angry or anxious, or having some depressive symptoms or something like all of that. Anybody feel like that this was a reasonably accurate reflection of you?
I think mine was.
Jordan, yours
I
was?
think mine was too.
Yeah.
Okay. All right. Because if you don't, then I would ask you, we would then need to kind of ask, like, why not? Like, were you not honest? Did you not understand kind of what the questionnaire was asking? And we tend to tell people not to overthink this, like just kind of the first thing that pops into your head when you think, yep, I kind of been doing that. Like, don't sit there and contemplate, okay, have I been feeling muddled over the last 2 weeks? Wait, I got to think about this really, really hard. So you just kind of this first blush, here we go. Okay. So that's the idea behind using the palms. And we will come back to the palms more towards the end. Because one of the things that the palms has consistently shown us and been used for is this is a really useful questionnaire to use with people that are changing their activity levels. Okay, so people that are sedentary will tend to have, in many ways, a certain look on certain dimensions of their palms, and then as they become more active, as we change their physical activity, then their mood states very often will begin to change. And so a couple of these things will track with changes in activity. There's also been some really fascinating evidence that we can use the palms by asking athletes to complete one every couple of days or every day, and looking at how their palms looks, and then we can alter what we have them do from a training perspective on that particular day based upon what their mood is. And sort of there are a couple of these things that will tend to track with people that are what we might call stale or overtrained to some extent. You've been doing too much, and so this can give us some guidelines on when it might be useful to kind of dial back your training intensity and have a lighter day or have a more fun day, and then have you go off and have a good meal and get some sleep, and we can fix things. So there's been some evidence. People have followed Olympic athletes and kind of used this to guide their training, and have some really interesting results. So we'll come back to this one, okay? But I wanted to kind of present that first. So before we get back into all of that, we're going to talk about what I think of are as the two most common kind of mood disorders that you guys are going to come into contact with as college students. Okay, and so one of those is anxiety. And anxiety is really, really important because it's the most common type of mood disorder or emotional illness that we will encounter. Okay, so the data tells us that about 20% of people will develop some type of an anxiety disorder that potentially warrants treatment. Okay, so 1 in 5 of us. So if we include me, there should be 24 of you guys in class plus me. So that would tell us that there would be 5 of us, okay? 5 of us that would potentially have an anxiety disorder, okay? So that's a pretty, kind of a pretty significant portion of the population. And to be really honest, if we look, then we do tend to see anxiety disorders to be a little bit higher in college-age individuals, especially in college-aged women. In general, you guys are a pretty anxious group, okay? And there's a lot of reasons why that might be the case, and why it might in some ways be transitory, based upon your circumstances, okay? So you all may not think about this in the same way that you think about, say, cardiovascular disease, or even like osteoporosis or low back pain that are going to cause like disabilities. But you may not think about the healthcare cost and the cost of lost work productivity that may be associated with these mental health disorders. And I think it's a really under kind of appreciated thing. So we think that there's about somewhere between 45 and 50 billion dollars in healthcare costs associated with anxiety disorders every year. Okay, so this is not a small sort of sum of things. People have anxiety disorders that will cause them to miss work. It will cause them to not perform their job to its optimum, level. They will have anxiety disorders that will require therapy, and you have to access healthcare costs because of all of that. And then, we're not even kind of monetizing the emotional cost of some of this. Okay, as I said, it's about 60% more common in women than in men. In y'all's age group, there may be some circumstantial things that are going on We do think there may be some societal issues that are going on, and then there's also certainly less so in y'all's age group, much more so in people that are maybe your parents or my parents' age. There are some kind of societal gender role issues, whereby men may be less willing to admit that they are experiencing anxiety, less willing to try to go and seek treatment or therapy or something for all of that. Again, it tends to be more common in Caucasians than in other ethnic groups. We also think that a lot of that is kind of, we'll use a buzzword that has been around. That's probably more of a privilege issue than anything else. In a lot of instances, this is a socioeconomic status type of thing, and that may in some ways also be an issue surrounding kind of women. It tends to be most common in kind of middle-aged, middle to upper class Caucasian women. And this is you're going to see this, and it's going to be reported in people that have access to healthcare, people that have enough education to understand kind of that anxiety disorders are a thing and that they are real, and that treatment in those other kind of interventions can actually be helpful. Okay, and so there's less stigma in sort of that socioeconomic kind of class of things. Plus, you're going to have healthcare that will cover it, so you can go and get treatment. It's going to be there. And so there's plenty of other sort of ethnicity. If you kind of pull out ethnicity, a lot of healthcare stuff is going to fall along socioeconomic lines, as much as it is just kind of purely an ethnicity issue. Okay, so that's some kind of general information about anxiety. So let's dig in a little bit on kind of what is anxiety and what is it like to have an anxiety disorder. And I will share some of my own sort of personal experiences with that, because I think it's important and kind of pertinent. Okay. So anxiety can be defined as the subjective feelings of apprehension, worry, and tension. Okay, and we'll talk a little bit about how that may manifest itself in the next couple of slides. There are what we call cognitive symptoms and somatic symptoms. So there are thought process symptoms, but the somatic symptoms, there may also be some physical symptoms that are going to accompany all of this. Okay, so the real thing, when you are anxious, you worry about things. Okay, that's really what it is. An anxiety disorder or having anxiety is about worry, right? And that worry then creates sort of these sort of different cognitive processes that are going on. And it may be associated with what we call obsession and compulsion. As you guys will see, that's a form of anxiety disorder. But just thinking, as you worry about something, you just think about it over and over and over again. Okay, that is a level of kind of mild obsession. It may not rise to the level of being obsessive compulsive disorder, but anytime that you're worrying about something, it's always there, or it's there more often than maybe it might not be. Okay, and then that can lead to these altered thought processes where you run through these different scenarios in your mind, like if this happens or this happens or this happens or this happens, here's how I would react, right? Or I have to talk to this person today, right? I can remember doing this when I was a student, like, I need to go talk to my professor today about this one particular thing. Okay, and I would try to play that scenario out in my mind, like, okay, well, I need to say this, I need to say this. Well, what if they say this, or what if they say that? You know, and you're worried about, like, well, what if they say something that I haven't kind of prepared for and I'm not expecting in many ways. Okay, so it can manifest like that. Okay, anxiety is not fear per se. Okay, in many ways. Now, phobias or specific phobia disorders are types of anxiety disorders. But when you're worried about something, if you are apprehensive and you're worrying about your grade in my class, or you're worried about the test tomorrow, or you're worried about the project that's due on Friday, or whatever else you're worried about, okay? You're worried about, is somebody going to swipe right or is it left on me on Tinder? I don't know which one of those things are. But you're worried about those kinds of things. It's not specifically fear, okay, because it tends to be more prolonged, okay? If you're afraid of something, then it tends to be fear is more of an emotion. In a lot of people, if you don't have a phobia, it's more of an emotion. Doesn't last that long. And in a lot of instances, fear has a very obvious external stimuli, right? So I could walk out my door right now and I would probably see several wasps. I am like terrified of wasps and bees. Okay. My wife laughs at me about this all the time. And because I am fearful of them, I worry that causes me anxiety about our daughter being out in our backyard around them, that she's going to get stung. I've only ever been stung once in my life by a wasp. It was incredibly unpleasant. I think I was 25 years old before I had been stung, so I didn't really have any like really bad experiences to make me afraid. I just don't like them. I'm outside, I see a wasp, I'm afraid. That causes me to move around and do something. When I'm away from the wasp, then fear goes away. Okay, that's not anxiety about a wasp. I'm not then thinking more so about what will I do the next time I encounter a wasp. Okay, so that's kind of the difference between worry and fear. Very often, although not exclusively, when you're experiencing anxiety, it may be combined with changes in the autonomic nervous system. Okay, so we will talk about some of these somatic or kind of physiological symptoms of anxiety. A lot of them are going to look like what happens when you increase autonomic nervous system function. This is this idea of the fight or flight kind of response. So you may see elevations in heart rate. You may see flushing and shooting of blood flow away from your stomach and your kidneys out to your skin and to skeletal muscle. Okay, you may see changes in respiration. And so we'll kind of get into a few of those in the next thing. But that's why those are going to be those very, very predictable kinds of symptoms, is that I worry, I release epinephrine and norepinephrine. And so then that's going to drive some of these physiological changes that we see. Okay, so the other key thing to appreciate when we get into anxiety is the idea of what we call state anxiety compared to what we call trait anxiety. Okay? A psychological state or a mood state is how you feel right now at this exact moment. Okay? What is your state? A mood trait or a psychological trait, in this instance, trait anxiety, is much, much, much more prolonged. Okay, we can argue about whether or not state anxiety is truly a mood. That if it's how do you feel right now, that it may be an emotion. But I could say, how have you felt, kind of the last couple of days? That would be state. Trait is just generally. Think about over the past several months, the past 6 months or so, the past 9 months or so. In general, how much are you worrying? How often are you experiencing apprehension and worry and things of that nature? Okay. So the questionnaire that I had you guys fill out, that we'll look at some numbers on all of that in a few minutes, it has one side that assesses state anxiety and the other side assesses trait anxiety. Okay. And so generally, trait is what we're going to use to try to, that questionnaire can in fact be used to clinically diagnose somebody as having an anxiety disorder. It's generalized anxiety disorder. You're just generally worrying about things. Okay, and we'll talk about kind of where your score cutoffs are going to be with all of that in just a minute, and I'll share what mine is in a lot of instances. Okay, trait anxiety in people that have anxiety disorders, and in general people that don't have anxiety, trait anxiety tends to be much more stable over time. If I'm a person that has an anxiety disorder, my trait anxiety is going to tend to be elevated all the time, right? All the time. No matter when you ask me, it's not going to fluctuate very much. State anxiety is very context dependent. It may be, it's the end of the semester, I have a couple of finals, I'm anxious. And then next week, I've got nothing, I'm off for a month, right? I'm going to the lake every day, or I'm sitting by the pool, or whatever it is that you like to do to chill out. And then my state anxiety goes way, way back down to kind of a lower level because of all of that. Okay? That's not to say, though, if you have an anxiety disorder, you may have days where you're not very anxious, where your state may be low. Okay? But that's kind of the idea behind those two things. So the other question that we don't have a good answer for with anxiety is, what is the root cause? And to be completely honest, we do not know the cause of anxiety. Okay. There is some evidence that there may be neurotransmitter imbalances in some kinds of anxiety, but it's not consistent. It's not the exact same thing in everybody. It's not like everyone that has generalized anxiety disorder has this one specific profile in the ratio of dopamine to serotonin in their brain, or GABA to something else in their brain. That's there's some evidence on some things, but it's not super consistent. Are there people that have changes in the way the brain processes information? There are cognitive changes in how you think about it and how you process things. Sure, in some people. Is it environmental? It can be. Certainly it can be. Okay. Is it genetic? Yeah, there's got to be a genetic component. My mom, even though she refuses to go to see a clinical psychologist, I promise you that my mom has generalized anxiety disorder. It's very, very obvious. If I was to guess, I think that her mom had generalized anxiety disorder from what I remember of my grandmother. It's just a thing. So there is this genetic component, which of course now makes me apprehensive. I worry about whether or not my daughter Ellis will also have an anxiety disorder. I worry about how much she's going to worry about things, which is just what somebody with an anxiety disorder would do. Okay. Are there other things that are going on? Yeah, absolutely. And so this is one of the reasons that it makes it difficult for us we can't treat all types of anxiety in the same way. And is it possible that your anxiety, if you experience it, is going to kind of shift over time from one cause to the next? Absolutely. Okay. So that's one of the reasons why, as you guys are going to see, that physical activity can be such a potentially useful treatment, is because it seems to work for almost everybody. Whereas other types of like cognitive behavioral therapy or particular drugs or something may work for some people, but not for others. Okay. So I've mentioned this just a little bit before, but we often will break anxiety disorders down into several categories. Okay. The most common one is something called generalized anxiety disorder, or GAD. That's the anxiety disorder that I have. Okay. If I was to guess, if we said that maybe 5 of us in the class would have an anxiety disorder, probably, I don't know, 3 or 4 of the 5 would have generalized anxiety disorder. Okay. This just means you worry about things in general, right? Um, and so it's a little bit different than having a phobia. If you truly have a phobia, like you are an arachnophobe, then you are afraid of spiders. Now that looks like fear because there is an external stimulus, right? Spiders, but you may actually be afraid of them and worry about them even when they're not like specifically right there in front of you. Okay. Panic disorders are types of anxiety disorders. That's not to say that anybody that has a panic attack has a panic disorder. You can not have an anxiety disorder and have panic attacks. You can have a different type. Like lots of people that have generalized anxiety disorder will also have panic attacks, but panic disorder is a little bit different. Okay, obsessive compulsive disorder, and it can exist on a continuum from being very, very mild, or people having sort of somewhat obsessive or somewhat compulsive behaviors, to very severe OCD, which is what a lot of people will think about. The deal where people have to obsessively and compulsively like wash their hands, and they will wash their hands over and over and over again until it feels just right. Or that the soap hitting their hands feels just right, or they will, touch the thing 3 times but not 4, and there are those kinds of things. That can be a very, very severe OCD. And then post-traumatic stress is also an anxiety disorder. Okay, and so we're learning more and more about post-traumatic stress. I'll mention a couple of things later on. I'll show you guys some data from the mood states profiles in Marines that were going through boot camp. But we're also learning there's some things. There's a thing called Gulf War syndrome, and then which looks a lot like something called chronic fatigue syndrome. But there's a chance that all of those things are forms of post-traumatic stress that the kind of mechanisms and the way they present are all going to kind of maybe be the same. And so that's an area where we're continuing to do more and more research. and try to get a better understanding of the things that that cause the trauma. And it doesn't have to be, I was deployed, and I was in a tank and we were, blown up by an IED, or I was shot at by the Taliban and they killed my buddies, or I was raped, or I was in this really, really traumatic car accident where my friend died, or something like that. It doesn't have to be things that are that potentially traumatic, that can lead to post-traumatic stress. So we need to learn more and more about those areas. Okay, so I'm gonna focus a little bit on GAD, and then share a little bit of information about the effects of physical activity on generalized anxiety disorder, and then we'll take a little break and we'll come back and we'll do depression. Okay, so what I'm going to show you guys here right now is this is information from what's called the DSM, but it's the diagnostic manual that clinical psychologists or psychiatrists who are MDs that focus on psychology, that they would potentially use to diagnose people. Okay, and so generalizing anxiety disorder is going to have this unrealistic or excessive worry about 2 or more life circumstances or life events for at least the past 6 months. Okay. Now, what qualifies as unrealistic, what qualifies as excessive, that's going to change based upon who you ask. Okay. So, like, I could ask Madison what she thinks is unrealistic or excessive to worry about maybe the test tomorrow, and her answer may be very different than what Judy's going to say. And so part of this that we're going to see is that people that have anxiety disorders, like me, you just worry about things, and so you don't realize that it's unrealistic or that it is actually excessive. I'll talk about kind of that in my own diagnosis as we move along. People typically will have difficulty controlling or coping with their anxiety and worry. And so if you can probe correctly and ask the right questions, you can see that their worry about things are going to have potentially negative impacts on behaviors and things like that. And so that's because you have a difficulty coping with all of that. Okay. You may alter your behaviors based upon your worry, depending upon what it is that you're worried about. Okay. The source is not due to panic, social phobia, obsession compulsion, or weight gain. Okay. Those can, the weight gain side of things we're going to talk about. That's kind of getting at eating disorders, and that's a separate, anorexia and bulimia are kind of separate issues that may be kind of obliquely related. All right. And then you need the presence on most days over the previous 6 months of some of the following symptoms. Okay. Feeling tense, wound up, or restless, easily fatigued, trouble concentrating, irritability, having tension in your muscles where you're just like this, and then difficulty sleeping. Okay. And so that I know for me that, I very often have difficulty sleeping. I do feel tense and kind of restless and wound up all the time. I'm irritable when it's bad. I'm irritable a lot. I'm not necessarily experiencing like concentration trouble, but a lot of people do. And part of that, it doesn't mean it's like you just can't concentrate, like you can't think about things, but it's you just get caught in that cycle of, I need to be working on this one thing, but I keep then having my mind shift over to this thing that I'm worrying about, and it may be hindering my ability to concentrate on and accomplish these other things that that I'm supposed to be trying to do, that I would like to do. So when we survey people about all of this, we tend to ask about what I said are cognitive symptoms and somatic symptoms. So the cognitive symptoms are many of the things that you guys filled out and completed in the STAI. This is the State Trait Anxiety Index. Things like, do you feel calm? Do you feel tense? Do you feel nervous? Do you feel relaxed? I am presently worrying over possible misfortunes. Okay, it's asking questions about what are you thinking, what are you feeling, okay, at that particular moment, or how are you been feeling about those things over, say, the past 6 months. The somatic scale, I didn't give you guys a somatic anxiety scale, but there is one called the Body Awareness Scale. And I think that there's a couple of questions that are going to get at the somatic scale in the profile of mood states, but this is asking about what we might think of as more physical or physiological symptoms. My heart is pounding. My mouth is dry. My hands are shaking, right? My vision may be blurred. I feel cold. Okay, there are things that are gonna be much more physiological and that are associated with overreactions of the sympathetic nervous system. Okay, so let's talk about exercise and physical activity and anxiety, and I will show you guys some data on this, and then we'll use that data as a jumping off point to talk about how you guys did on your state trait anxiety index. Okay, so things to consider when we're looking at exercise and physical activity and its effects on anxiety. We need to be cognizant of, are we looking at the effects of exercise on state versus trait anxiety, right? So is the exercise changing my anxiety right now today, right? Or is it changing kind of my general feelings on things? We have some evidence on both, okay? Who are we asking? Who is our sample? And so what we tend to see is that people that have more anxiety in general will tend to benefit or have greater reductions in their anxiety due to increases in physical activity and exercise than people that don't. From a research method standpoint, we sometimes call this a floor effect. That like the floor is the bottom, that if you're very near the bottom, you have very little anxiety, then there's not a lot that exercise can do to lower it much farther. Whereas if you're somebody that is very high, you've got much larger kind of range to be able to lower things down. It's important for us to understand when the anxiety is measured. You guys will see some kinds of physical activity have kind of very immediate effects on anxiety. Some have more delayed effects on anxiety. And then we also need to consider how many times is it measured? How many times are we measuring before? How many times are we measuring after? Are we measuring it enough and in the right time frame to be able to capture any kind of a change that may or may not take place? So what I'm showing you guys here, okay, is here are the effects of acute levels of acute exercise. Okay, and this was, I believe it was a bout of cycling, acute exercise on state anxiety. So how anxious are you right now on the STAI? And what I'm showing you guys are, here is where the people are kind of normally, okay? Here's where our people are right immediately before we have them do the bout of exercise. So red is exercise, blue is a control condition where they just sat there, okay? And then we assessed their anxiety during the bout of exercise, and then at 5 minutes, 20 to 30 minutes, right, to 3 hours afterwards, after our bout of exercise. So kind of what happens. So these are very acute effects of exercise on state anxiety. And I'll explain what this white line is here in just a minute, okay? So what you can see, these are non-anxious people. So, but what you can see is that when they know they're going to have to exercise, they get a little bit anxious beforehand, a little bit more anxious than they were beforehand. During the bout of exercise, weirdly enough, people do tend to see increases in anxiety during exercise. Okay, during exercise, and then it falls in the aftermath of exercise. In a lot of instances, these people aren't anxious, but they did fall a little bit farther kind of down than where they were to begin with. And you can see that with the control, there's not really a lot going on, kind of very little change that is happening over time. Okay, these are in non-anxious people. So you can imagine people that are anxious, that do have an anxiety disorder, will tend to be up here in the cutoff points, the cutoff score for state anxiety for people that are potentially at risk of an anxiety disorder is going to be here in the high 30s. People that have an anxiety disorder, their trait anxiety, which is the one we typically will use to diagnose, are going to be up here in the low 40s. That's kind of the cutoff point. So if you're above the low 40s, there's a reasonable chance that you have generalized anxiety. So they're going to be up here. And we see that in general, the same kind of response in them where it goes up during exercise. Most of that we attribute to the fact that you increase heart rate and breathing and some of these things during a bout of exercise. That your somatic symptoms go up. And so it's not that you're really that much more stressed. It's just that you're getting the sympathetic nervous system response during exercise. And then it will tend to fall back down afterwards. Okay? So I'm not going to show a huge amount of data on all of this. I'm just going to summarize some things. But in general, following in the immediate aftermath, following a bout of exercise, almost everyone feels less anxious than they did beforehand. Okay? All age ranges, men and women, novice and regular exercisers, people that are low anxiety and people that are high anxiety. Okay? So one of the most consistent findings, okay, the most consistent findings in exercise psychology is that an acute bout of exercise lowers perceptions of anxiety, okay, in everyone. So what kind of exercise does this? Well, there's been a lot of studies on this, and we have found that aerobic exercise of almost any intensity, so there is not necessarily a percentage of VO2 max, or it's not like a threshold or anything. Walking, jogging, running fast, okay? Crawling along on a bicycle, going very, very slowly, bicycling to moderate. So almost any intensity is going to be sufficient to make a person feel less anxious. Resistance training also lowers anxiety, but it has a strange kind of different effect. Resistance training, people tend to not feel less anxious right afterwards. There tends to be a delay of maybe 90 to 120 minutes, so an hour and a half to 2 hours later after the resistance training. That tends to be more of the window of when people are going to feel less anxious. So what I can tell you guys is, if right now, today, you're anxious about our test tomorrow, go work out. Go for a run, go for a walk. You'll feel less anxious, okay? Almost all of you. Now, for those of us that are higher anxiety, we're not going to magically, all of a sudden not have any anxiety anymore if we just exercise every day, but it can be very, very effective. Okay, it can be very effective. Here is a study that was published in the late 90s. And I like it because it's comparing the effects of aerobic exercise or exercise training to people taking a selective serotonin reuptake inhibitor, or an SSRI drug, one of the more commonly prescribed drugs for anxiety. Okay, so here you can see this is not on the STI. This is on what's called the Hamilton Anxiety Index. But again, higher scores represent people that would be more anxious. And so they're taking people that are quite anxious, okay? In the black squares, you can see this is what happens over 10 weeks to their anxiety scores when they were doing aerobic exercise. I believe it's 3 times a week for up to an hour. They kind of work their way up to an hour of doing 3 times a week aerobic exercise. Okay, the black circles with the dotted line, this is a separate group of people that are taking clomipramine, which, as I said, is a SSRI drug. And then the group that is, you can see in the open white circles, was a group that they didn't exercise, but they got a placebo. And so we call this a randomized control trial and we call it being double blind, because the people getting placebo and the people getting clomipramine were not told what they were getting. They didn't know if they were getting the actual drug or if they were getting a sugar pill. And so what I want you to look at, the 2 kind of big takeaways. One, the exercise appears to be approximately as effective as the drug at lowering anxiety, okay? And then also look at, I give people a placebo and it works for a month. These people are not getting anything other than a sugar pill, and they're going to feel less anxious for about a month. But then over the back 6 weeks of the study, they're going back up to about normal. This is a very, very, very common finding in all sorts of research. We call this a placebo effect. Okay, where the placebo is really working. right? Like it's not fake. It's actually working, but it will stop working at some point because it lacks the thing here. Okay, why does exercise or how does exercise lower your anxiety? We don't really know. Okay, I'll be really honest with you guys that we don't have a good sense of all of this. We have multiple hypotheses that we think are going on, okay, but the actual thing may vary from person to person and is probably going to be due to some combination of several of these hypotheses, okay? There are both physiological and cognitive explanations for how exercise lowers anxiety. Exercise does lead to the release of something called endorphins. Um, and endorphin is a general term. You're going to actually release a host of things that we call endogenous opioids. Your body can make substances that are essentially analogs to morphine. Okay. Your body also makes things that are called endocannabinoids. Your body makes its own marijuana. Okay. So there's a host of different endorphins. Um, some of them are more effective than others, but exercise can lead to the release of these endogenous opioids. They make you feel better. Okay. You're less sensitive to pain after exercise, which is one of the things that we study in my lab. There is potentially some role for these endogenous opioids in that as well, but there may be some role for that in why people feel better. Okay, although we can block the effectiveness of these things, and people do often tend to continue to see lowering of anxiety. There may be re-regulation of what we call the monoamines. These are neurotransmitters, so serotonin, dopamine, norepinephrine. Which is one of the reasons that when you take like an SSRI drug, it's trying to alter the amount of serotonin that's in your brain and the ratio of serotonin to these other things. So we know that exercise can alter kind of the release of those and the amount of those that are in the brain in certain areas. That may play some role. Weirdly, thermogenesis may play some role. Exercise raises your core body temperature, and there is evidence that raising your core body temperature to some extent is actually really, really good for your health. That it may be good for anxiety. So go get in the sauna, go get in the hot tub, go take a really hot shower. We don't know kind of the hows and the whys, but we do see that it's associated with those things. There's some really fascinating evidence from kind of Russia and kind of Northern European, Scandinavian countries where bathhouses and saunas are really, really popular. And the people that go to those very regularly tend to have kind of lower anxiety, lower depression, and less cardiovascular disease. Increasing blood flow through thermogenesis is really good for your blood vessels. So there you go. Go buy that hot tub, everybody. Get in that hot tub every day, okay? There's also potentially, especially with group exercise, the sense of social interaction can be really good for anxiety. And then the sense of achievement may lower anxiety. The fact that I went and I did something today may be a sense of achievement, or I ran a mile at a particular pace that I've been trying to get to. So that gives me this sense of achievement. Or I ran a half marathon. Like that achievement can be, can manifest itself in a lot of different ways, but it makes you feel better about yourself. Okay, the social interaction is good. And you guys will see that these two things are also going to be really, really important for the effects of exercise on depressive symptoms. Additionally, it may just be a distraction, right? The exercise is unpleasant or the exercise sucks. So you focus your cognition on that. You focus on the fact that the exercise is happening and it is not fun, or that you're achieving something. And so you just stop thinking about the things that you've been worried about. My wife talks about that. That's how she feels like that exercise is really good for her. This may be one of the ideas behind yoga, right? Be present. Don't think about what you got to do tomorrow when you're doing your yoga. Just sort of be in the moment, be present. Think about what your body is doing. Think about your stretching or your meditation and those kinds of things. So that may also be a way that exercise is doing things. Okay. So let's take a quick break here. Come back at 11:55. We'll talk about my anxiety. You guys will talk about what your scores are going to look like, and then we will get into depression. Okay. And we'll turn the screen share back on, and let's talk about depression a little bit. Okay. So depression is not nearly as prevalent as anxiety. Okay. But in a lot of ways, and this is not to make light of that anxiety is not a real and serious issue that causes lots of people lots of issues. Depression is the one that in general we tend to worry more about. Okay, because depression tends to be the mood state that leads to suicide. Okay, and so that's the one where sometimes the bad outcome can be really, really bad. So depression is prolonged, intense, and overwhelming feelings of sadness and loss of pleasure in activities, especially things that you used to enjoy. Those things now are not going to be enjoyable. We'll talk about that when we get into the diagnostic definition. Okay, so we'll run through this, and I think this is really a kind of a very telling statistic about where we are with depression and why it's such a problem. Okay, so unlike anxiety disorders, okay, I have had anxiety probably all of my life. I probably will. That disorder is always going to be there. Depression, in a lot of instances, the diagnostic criteria for depression are much shorter. Okay, so people will become depressed and then get better, and then maybe become depressed again and then get better. Okay, and so we tend to think that about 1 in 3 people will have clinical depression at some point in their lives. And once you've been clinically depressed, you can and will very often eventually feel better, and it may or may not ever come back. Although people that it tends to be the worst, and it will return. My wife's college roommate has depression and deals with it. Partially, we think because of all of that, she has a PhD in clinical psychology, and she works at a medical school in North Carolina, and she teaches the doctors how to do better at diagnosing people with depression and anxiety and mental health disorders. So kind of a fun job. But about 1 in 3 will become depressed at some point. Somewhere between 5 and 10% of people are depressed at any one given time. So if maybe 1 in every 5 of us in class are going to have an anxiety disorder, that maybe one person in class, maybe two. There's the data would suggest that there's probably one of you guys in class that would be clinically depressed right now. Okay. The economic cost of depression, even though it is less prevalent than anxiety, is very high. It's about $40 billion or thereabouts a year. From a lot of depression, economic costs are associated with people having lost work productivity. Okay, they're not going to work. It's not that they're necessarily having to access health care. It's that there's work productivity, there's work and things that's not getting done because of it. So if depression affects 1 in 3 people throughout their lives, only a third of the people that are depressed will seek treatment for their depression. So 2 out of 3 people that are depressed at some point will not seek treatment. Of that third of people that do seek treatment, only about 1 in 3 of the people that get treatment find that treatment to be effective. Okay. And so, it's like a ninth of people that are depressed actually get treatment that is beneficial to them. And so that to me is an alarming kind of an issue. So a lot of people don't get treatment. Okay. They just try to struggle through and deal with it. And then the people that do get treatment were not very good at treating it. And so I don't want that to be alarming. I don't want that to mean that we shouldn't seek treatment. They're constantly trying to get better and better at this. We need treatments and those things, but it can be really tough. Okay. So here are the diagnostic criteria. They're a little more prescriptive than anxiety disorder. So you need to have one of the first 2 symptoms here, and then at least 5 of the remaining 7 almost daily for the previous 2 weeks. Okay, so the anxiety ones are over 6 months. This is just for 2 weeks. So sad mood most of the day, nearly every day, or a loss of interest or pleasure in previously enjoyed activities, whatever that might be. Okay, I love playing Fortnite, or whatever your video game of choice is. I love playing with my dog and taking my dog for a walk. I love taking naps, whatever. Okay. So sad all day, nearly every day, loss of interest or pleasure in previously enjoyed activities. That's one of those. You get one of those two symptoms, and then 5 of these next 7. Okay. Significant change in appetite or body weight. Does not matter. Could be up, could be down. Okay. Insomnia or hypersomnia. So it's a marked change in your sleeping patterns. You may sleep way less or you may sleep way more. It's just this very big change from normal. Okay. Being lethargic or being super agitated. Okay. Again, either one of those, it's just this big change from normal. Fatigue or a loss of energy. That's kind of a big one. It's going to be there. Okay. Um, Feelings of worthlessness and excessive guilt. This is a hallmark of depression. You feel like I don't have anything to offer to anyone. I feel worthless. Okay. I feel guilty about that I'm a burden on my friends or my family or other people. This is a very, very hallmark thing of depression. And it's this worthlessness and guilt that tends to kind of link into and drive the 7th one down here, these recurrent thoughts of death and suicide. Right? Nobody will miss me if I'm gone, so why am I here? Right? I'm not any good at anything. I'm just a burden on other people. Why am I here? Things would just be better off if I wasn't here. Okay? So, um, as people like to say that have depression, or as the people that I know that have battled with depression, they like to say that when you are depressed, your brain lies to you, right? When I'm anxious, I worry about things. My brain's sort of lying, but with depression, it really lies. Okay, you have worth. People will miss you. People do care about you. You shouldn't feel guilty. Depression lies in many ways. Okay, so one of the first 2, 5 of the next 7. That's the clinical criteria. If you've had those over the previous 2 weeks, then that can be the case. All right. So many of you may be able to think back on a situation in your lifetime when you have experienced this. Okay. Depression is often brought on when people lose a close relationship. Okay. That could be a friend, that could be a family member, that could be that they move away, or something happens and the friendship ends. Okay, or you have a falling out with your family. It can be due to a death. It can be loss of a relationship with a significant other or a partner. Okay, those types of things can be very emotionally traumatic and can lead to depression in that way. So many of you may have had a situation where you have lost a relationship like that at some point in your life, and you may have been depressed for a little while afterwards. And like a lot of things that generally for most people over time, those things do get better. If you can just kind of muddle through, they do get better, but sometimes they don't. Okay. Depression, even more so than anxiety, does tend to run in families. So family history is going to play a big role. If you have parents or grandparents or something that have a family history of depression or other kind of psychological disorders, then you're going to be at a higher risk. As I said, a recent loss or a major stressful life event can lead to depression. Lack of a close relationship, or the perception in your mind that you lack a close relationship. Okay, feeling like I don't have close friends, I don't have a significant other, whatever that might be, I don't have things with my family. Lack of those relationships can do that. Okay. Depression tends to be a little bit more common in women than it is in men. Again, we think that's a reporting bias issue. We don't think there's anything other than maybe being postpartum in women, so recently giving birth. Other than that, we don't think that there's that much that's physiologically different between men and women that would make them that way. It's just that at times culturally we have told women that it's more okay to be in touch with their feelings and to express those things and to do things than sometimes we have been with men. Although I think we've turned a pretty significant corner. It tends to get better. Folks in y'all's generation, when they survey you guys, we get a lot more men that would say they would be willing to kind of express this, that they're having a hard time with things. The postpartum stuff is really really real. I will tell all of you, everyone, that, ladies, the postpartum, there is this massive change in hormones. One of our best friends, her daughter will be 3 in October, I believe, and she's a professor at a school in Savannah, Georgia. We went to undergrad with her, and she went to grad school and got her PhD at Georgia while we were there. So we've known Sarah for a very, very long time. She's a wonderful person, and she had a really, really bad postpartum depression. um, and she's always happy to talk about those kinds of things. But it's just this, that you shouldn't feel this way, or that you don't want to feel this way, and you can't do anything about it, and you're just like, I'm unmotivated, and I am sad, and I have this little baby, and I feel like that I should love this baby, and I should be so happy, and all of these kinds of things. And I mean, it's just these hormonal changes that have taken place, and it can be really, really bad. And then one of her other best friends has had 3 kids and has had no trouble whatsoever. My wife had a little bit for the kind of first few days afterwards that was relatively mild, and then she didn't have too much trouble. But I mean, the hormones, as they change, and you get this massive kind of going away of all this estrogen and progesterone and things, and it alters brain chemistry. So it is real, and it's normal, and it's very, very common, and nobody talks about it. So just kind of things to be aware of. And guys, we need to be aware of this as well, because we need to be there to be supportive and helpful. When wives or partners or girlfriends or whomever, if you're going to be a father, then this is going to be stuff that may potentially come up that you're going to have to deal with. Okay, so exercise to treat depression is probably the single most widely studied thing in exercise psychology. I'm going to kind of go through this really, really quickly, as we're kind of running out of time on things. The take home for exercise and depression is that no matter how we slice it, how we look at it, exercise is a really good treatment for symptoms of depression. Okay? People that exercise more are less prone to becoming depressed. People that are depressed, okay, are going to have less depressive symptoms as we can increase their physical activity. Okay? Much like with anxiety, exercise is, in a lot of ways, as good of, if not a better treatment for depression as any drugs that we have. Okay? It is comparable to all other types of treatments. There does not seem to be much of an additive effect to exercise and the drugs, but there's a little bit of data on a slide that I will show you guys here, that one of maybe the most powerful effects of exercise for depression is if you can get people to keep exercising. Okay, these were cohorts of people that had depression, that they took up exercising. They put people on medication, and they had a group that did a combination of exercise and medication. And to me, yes, the exercise works, and maybe it works a little better than the medication, but it's this other bar out here. Okay, these are people that were depressed, and they tracked them for a long period of time, and they looked at how often their depression came back, how often they relapsed. And the group that exercised and did exercise alone had the lowest rate of relapse of their depressive symptoms of any of the other groups. And there may be other reasons for all of this, but the folks that were taking medication are doing the combination, so maybe there's something weird about the medication that is making people relapse, that we don't fully understand. Okay, but exercise is as good a treatment for depression as anything else that we have. Okay, so when you feel sad, go exercise. Get out and do things. How and why does that work? Much like with anxiety, we don't know, we don't understand. Okay, is it changes in cognition? Maybe. Does it change the way you're thinking and processing these things? Is it a change in self-esteem? We do see a lot of changes in self-esteem and self-worth and self-efficacy with exercise. People feel better about themselves. They feel like they're accomplishing something. They feel much more worthwhile because they're out there and they're doing something. Okay. Is it changes in brain monoamine? So 5-HT is serotonin, NE is norepinephrine. Does it re-regulate those things? Maybe. Does it change things along the hypothalamus pituitary axis? Maybe. There's a little bit of evidence on all of that. Another thing that exercise does, especially if it's outside, is it may help us to re-regulate circadian rhythms. So one of the interesting things about depression is that it seems to be related in some ways to exposure to sunlight. Okay, and so you have these circadian rhythms, which are gonna rule your sleep-wake cycles. They're not quite on a 24-hour schedule, but they're not too far off of all of that. One of the things that we know is that in places that have very high or very low latitude, so near the North Pole or the South Pole, where you go long periods of time without there being sunlight, okay, is that people tend to be much more affected by something called seasonal affective disorder. If anybody is like me, and my wife is probably worse than I am at this, when we do the fall backwards in the fall, when we go away from daylight savings time, when it gets dark at 4:50, it really messes me up. Where I do not like that it takes me several weeks to adjust. Whereas when we go to the daylight savings time in the spring, where you're going to get more sunlight later in the day, I don't have nearly the same kinds of problems. More sunlight helps to regulate your circadian rhythms. It releases melatonin. It does some things that it helps regulate circadian rhythms. And so what we see, strangely enough, in like Scandinavian countries, is that they have the highest quality of life and the highest ratings of happiness and life satisfaction of anywhere in the world. And yet, paradoxically, they also tend to have the highest suicide rates. Okay, and we think that a lot of that is related to in some of those countries, it's dark 6 months out of the year, and that their suicide rates tend to go up, their depression rates tend to go up when it's dark. And so they're the most active countries. They have the highest standard of living. They have the best education systems in the world. They have the highest quality of life, and yet they also have the highest rates of suicide. So just some things to think about with all of that. So if you're not feeling great, you're feeling kind of sad, you're feeling blue, you're feeling down, get outside, okay? Get some sunlight. Just go walk around. Go walk your dog or something, or go borrow somebody's dog. Maybe go stalk a dog at the dog park. Let a dog lick you in the face and do that, and you will hopefully feel better. Okay, from a time standpoint, I'm going to breeze through these last couple of things really quickly. So I mentioned earlier on that I was going to show you some data from Marine recruits going through boot camp, and so that's what this is. And what I want to illustrate with this is the very, very powerful effect of kind of feelings of achievement and potentially high levels of physical activity, all while you're getting kind of yelled and screamed at and accomplishing really, really difficult things here. Okay, so these are profile of mood state data in female Marine recruits at the start of and then at various points through to the finish of boot camp. Okay, so you can imagine, right? This is on the same scale that you guys had. So here we have kind of a reference. These are somewhat kind of high normal age matched females are going to be here in gray, and then we have them at the end of their first week of boot camp, and then we're going to go at week 5, at week 8, and week 12. And I want you to note that on our negative mood states, fatigue, depression, anger, tension or anxiety, and confusion are all significantly elevated during the first week of training, right? You can imagine, at least I can imagine, like what Marine boot camp is going to be like, right? We've got to break you down so that we can build you back up, and kind of all the physical and mental challenges that are going to go into that. And so these people are super duper active over the course of it. And then watch what happens to all of our negative mood states by the time we get to the end, okay? They're not very fatigued. They're not nearly as depressed. They're not as angry. They're not nearly as anxious. They're not as confused. And their energy levels, their vigor is going to go up and it's going to increase. Okay. And so to me, this is a very powerful illustration of how we can see these acute changes in mood states and things as a consequence of exercise and feeling like you can accomplish these really difficult tasks and things that are going to be both physically and mentally put upon you through everything. Okay, so we do know very, very well that exercise training makes your energy levels go up and make your fatigue levels go down. Okay, we see this in people that are sedentary. When you take people that are sedentary and you have them exercise, they're going to report being less fatigued and they're going to report having more energy. Okay? There are also some clinical fatigue conditions or clinical conditions that tend to have a lot of fatigue. People that have undergone or just undergone radiation and chemotherapy treatment in cancer, people with cardiovascular disease that are kind of post-heart attacks, they report high levels of fatigue, low levels of injury, of energy. When we exercise them, their things will improve and their things will go up. Okay. Then there's the athletes. And this to me is really fascinating, and I'm going to talk about this by showing you data. Okay. So these are some very old data, but it's using the profile of mood states. And these were data that were collected in the 70s at the University of Wisconsin by a guy who was a psychologist that was one of the first people to study the effects of exercise on psychology and mood states and those things. His name was Bill Morgan. And what you can see here is what he termed the iceberg profile. And so the way that these data are presented here is that each sort of section of dots or squares is going to represent the scores on one of your palm's mood states. Okay, how far up this goes versus down, this is the scale or the intensity of this particular mood state. And so this is a longer questionnaire. Okay, I believe its scores went to 80 or 100 on all of this. Okay, so it's not your scale, but we could make something similar to this using the ones that you guys did. Okay, and so the red line here at 50, these are the normative values. The way that this scale was originally designed is they fixed it so that 50 was the midpoint or the mean score in kind of normal everyday people. Okay, and so what you have here are different groups of elite college distance athletes. So we have runners, we have wrestlers, okay, and then they have oarsmen, so rowers. The University of Wisconsin, especially their men's rowing team, I think was at the time was really, really good. They have additional data on this from swimmers, okay, and a whole bunch of other things. And what you can see from all of this is the reason they call this the iceberg profile is that on our negative mood states, so anxiety, depression, anger, fatigue, and confusion, our athletes tended to score below average on our negative mood states, and they scored well above average on the positive mood state of energy. Okay, so iceberg, things below the surface and then kind of a jutting out up above the surface. So this is a relatively common mood thing when you look at people that are athletes. They have this profile. They tend to have less negative mood state than the average person, and they tend to have more energy. Now, is that something genetic about part of what makes them a good athlete? Maybe. Is it a consequence of all the exercise that they do as part of their training and their sense of accomplishment and things that are going into that? Also, probably yes, but this is what it looks like. Okay. What we know now that they didn't know fully at the time, but they were about to research from Bill Morgan's lab, was that if you take an athlete and you put them at very high levels of training as a season begins or as an off season begins, and they ramp up their training a bunch, okay, that this distinctive iceberg profile flips. Their vigor falls, okay, and their depression and especially fatigue will increase. Okay, and so it's going to look more like kind of like a, not necessarily like a V, but you're going to get this distinct change. This is going to be a hallmark that the person may be training too much and they need a day off or a couple of days off, or they need to train but do it at a lower intensity on a particular day. And there's been some really fascinating studies that have been done using Olympic athletes and things. And this works really well in people that have long seasons where your training needs to build up towards particular events, like you're in track or you're swimming or something, and you're gonna use the first part of your season, even though there are meets and events, that you're going to use those to try to build yourself to peak at the very end of the season when you have, say, a conference meet or a regional meet or like a national championship meet or something, where you're trying to train so that you can peak to qualify for the Olympics and then compete at the Olympics, that people will titrate, like with, we call it titration, much like in chemistry, where they will titrate up or down how much training they do on a given day based upon their mood states. I can tell you guys that one of our former students works with the Thunder, and that they do some of this with the Thunder. Okay, they ask them every day some questions about what their mood state is, and they may change what they're having people do during practice on those particular days, or how much they're sleeping, or what they're doing based upon all of this. Okay, so it's kind of a really powerful, really interesting tool, that our best way in some ways to diagnose you as being overtrained is not a physiological change, it's a psychological change that we may be able to see. Okay, that's all I got. All right, and with that, I